Hello?
Hello?
Can you hear me?
Yes, we can. Good morning, Dr. Flynn.
I'm using my cell phone as a microphone. Can you see my slides?
Yes, we can.
Okay. All right. Well, thank you again for inviting me to participate. I'm sorry for the technical problems. So I'm very happy I could hear the last session and all the speakers. So it's a perfect lead-in to my presentation here today. Could we go to the next slide, please? I want to emphasize that endophthalmitis is not a never event. We certainly have our cases at Bascom Palmer. We have approximately 1 or 2 out of 5,000 cataract operations each year. We have approximately 1 out of every 2,000 vitrectomy cases. And so it does happen. Next slide, please. So the factors that lead to endophthalmitis after cataract surgery are shown on this slide, and they include the presence of severe blepharitis or lid abnormalities, a relative immune complex compromise such as the diabetic patients, wound leak, vitreous loss during cataract surgery, the use of a gel prior to application of povidone iodine, and contaminated solutions, as we have heard this morning. Next slide, please. So, preoperative topical antibiotics in the United States are a common standard of care. They reduce surface bacterial colony counts, but they are certainly not a guarantee against the presence or occurrence of endophthalmitis. Next slide, please. What about antibiotics in the irrigating fluid? The endophthalmitis vitrectomy study in 1990 to 1994 looked at this issue of 87 patients in which the history by the referring doctors was available. 10 of those patients developed endophthalmitis despite receiving prophylactic antibiotics in the cataract infusion fluid. So if rupture of the posterior capsule occurs, we know that the dilution of antibiotics will be reduced and therefore will be ineffective. What about, next slide, please. Povidone iodine. This is a low-cost, broad-spectrum way of reducing bacteria. It's widely available. Fast bactericidal effect within 30 seconds, and no antimicrobial resistance. Next slide, please. The new risk factors for endophthalmitis include all the injectable materials that we use in surgery. These include intracameral myocol or other solutions, epinephrine in the irrigating fluid, intraoperative dyes such as ICG, trypan blue, and the use of sugarcane, phenylephrine, and ketorolac. Next slide, please. We have heard this morning about the differential diagnosis of TASS and endophthalmitis. Sometimes it's very difficult to distinguish the two factors. Long and complex surgery can mimic endophthalmitis. Retained lens material, especially cortex, can resemble endophthalmitis. The diabetic patient with chronic vitreous hemorrhage can create a hypopyon that also resembles endophthalmitis. And finally, the use of triamcinolone during an anterior vitrectomy by the anterior segment surgeon can simulate endophthalmitis. Next slide, please. This slide shows a typical case with very complex surgery, damage to the iris by the phaco tip, corneal edema, inflammation. And so this is something that we always think about, is it TASS or is it endophthalmitis? Next slide, please. With TASS, we think of poor quality infusion fluids, sometimes mixing of sugarcane or other agents, intracameral antibiotics, certain viscoelastics, certain IOL solutions, and chemical or detergent residue on the ophthalmic instruments. Next slide, please. Dr. Edelman showed examples of TASS, and this classic photograph shows the wall-to-wall corneal edema in such a patient occurring on the first day after surgery. Next slide, please. This is an example of a patient that was seen by me presenting with a prominent hypopion, and yet the anterior chamber was completely quiet with no fibrin, perfectly clear cornea, and this is an example of triamcinolone injected by the cataract surgeon, and it came forward in the anterior chamber, giving this pseudo-hypopion. With observation only, you can see this steroid resolved by itself with time. Next slide, please. Let's go to intracameral antibiotics. We have three choices today: cefuroxime, vancomycin, and moxifloxacin. I will begin, next slide, with what are the risks of intracameral antibiotics. The first and foremost is TASS, related to mixing, the concentration, and buffering errors. Number two is cystoid macular edema, especially with the use of intracameral vancomycin. Endothelial toxicity or cell loss is another issue. With aminoglycosides, which are no longer used, the risk is of macular infarction or retinal toxicity. Finally, iatrogenic endophthalmitis during mixing of the agents can result from contamination. Next slide, please. So we published an editorial back in 2014 about the risks of intracameral antibiotics. The issues come as to whether or not they're truly effective. There's a short half-life of antibiotics in the anterior chamber, problem with mixing. The CDC recommends in the United States strongly against using vancomycin as a prophylactic or preventive antibiotic. It should only be used for serious organ-threatening or life-threatening infections. There is a high resistance of Staphylococcus, especially Staph aureus, and methicillin-resistant Staphylococcus epidermidis to moxifloxacin. There's certainly a high cost of using this on every case, and in modern surgery, the rates of endophthalmitis are very low, so it's very hard to prove the value of this approach. Next slide. Everyone in the room is familiar with the European Society of Cataract and Refractive Surgery study back in 2006. This involved 14,000 patients randomized to intracameral versus alternative approaches. Next slide. This slide summarizes the outcomes of that study. At the bottom, you can see combined totals. Intracameral cefuroxime was 5 out of 6,800 cases, or 0.07. With no intracameral cefuroxime, it was 23 out of 6,800, or 0.33%. So this was impressive data, and yet there were some shortcomings of this study. Next slide. The study was stopped prematurely. Cefuroxime at that time required reconstitution from a powder. It's now available in a pre-prepared method. There was a short-term stability of mixed powder. Cefuroxime is not ideal for Staphylococcus, potential contamination, and an unusually high rate of endophthalmitis in the control group. So there were many problems with this study. Next slide, please. So the downsides of intracameral cefuroxime include overdoses and mixing problems. And in one report, there were 7 consecutive patients with endophthalmitis caused by fusarium as a result of contamination during the mixing process with cefuroxime. Next slide, please. This is the abstract from that outbreak of endophthalmitis associated with fusarium during this procedure. So you can see these cases below are very difficult management problems of secondary fusarium infection after mixing the cefuroxime. Next slide, please. Again, the CDC, the Center for Disease Control in the United States, strongly recommends against the use of vancomycin. You can see that the routine use of prophylaxis in a patient with is discouraged, again, except in a situation of life-threatening infection. Next slide, please. Next slide, please. Thank you. So there are 2 reports out. First was in 2015 describing a condition called hemorrhagic occlusive retinal vasculitis. The second occurring in 2017, which is a further follow-up study, including cases across the United States, 36 cases of endophthalmitis, of hemorrhagic occlusive retinal vasculitis. Next slide. So what is this condition? This was described in detail of 11 eyes of 6 patients in the first report. Between 1 and 14 days after surgery, patients presented with painless loss of vision and showed extensive retinal hemorrhages, occlusive vascular disease, and resulting in some cases in permanently loss of vision and neovascular glaucoma. Next slide. Here's an example of a case of a patient that occurred 10 days after cataract surgery using intracameral vancomycin. This patient was seen at Bascom Palmer Eye Institute, and you can see the diffuse hemorrhages and obliterative vasculitis, optic atrophy in this patient with severe visual loss. Next slide, please. This is an enlargement of that same photograph. Now, the major difficulty in this case was that the other eye had surgery 7 days after the first eye. And next slide, you can see that the second eye of the same patient developed a similar problem at 1 week after the second surgery. You can see the severe hemorrhages and attenuation of vessels in this patient. Next slide. The fluorescein angiogram shows the marked attenuation of vessels and non-perfusion in the retinal periphery, which confirms the visual outcome with count fingers in the right eye and 20/60 visual acuity in the left eye. Next slide. This case is even more illustrative of the vasculitis, and you can see the marked periphlebitis, the involvement in all quadrants at 5/200, 14 days following cataract surgery. Next slide. Again, the fluorescein angiogram illustrates the widespread vascular abnormalities, cystoid macular edema, including subretinal fluid, in this patient with poor outcomes using the prophylactic technique of intracameral vancomycin for cataract surgery. Next slide. And here's the right eye, 9 months after surgery, hand motion vision, a very unusual picture. This does not look like a central retinal vein occlusion, but rather is a marked perivasculitis, which is felt to be a immune complex inflammatory disease in these patients with vancomycin. Next slide. Another technique is called Dropless cataract surgery. This technique uses transzonular injection of a substance called trimoxy. This includes triamcinolone and moxifloxacin, which is prepared and injected through the zonules into the anterior vitreous using a long 27 or 30 gauge cannula to reach beneath the iris to penetrate the zonules and inject the material into the anterior vitreous. This process in some patients can lead to severe problems. Next slide, please. In Dallas, Texas, there was an outbreak this year in January, between January and February, of 80 patients who developed what is now called the toxic posterior segment syndrome, as opposed to the toxic anterior segment syndrome. This TPSS can occur with inflammation in these eyes, causing severe loss of vision. The problem is contamination from the compounding center during the preparation of this medication. This product was pulled from the market, and this compounding center is no longer allowed to prepare this material. Next slide, please. So the pharmacy was cited for several problems. According to FDA records, sterilization issues, failure to document the suspension of drug products, and an operating facility that lacked adequate space for the orderly placement of equipment. So these are some of the downsides of using this trimoxy solution. Next slide. Next slide, please. This slide summarizes some of the more recent studies of intracameral antibiotics and the rates of cataract surgery. On the left, you see the authors and the agent that was used, C for cefuroxime, V for vancomycin, M for moxifloxacin. The largest series is at the lower part of the slide with Hari Prithia and associates from India, 600,000 cataract operations. But this study was not randomized. It was rather 10 hospitals in a hospital system, some of which used moxifloxacin and others did not. The studies in yellow showed no difference in the rates of endophthalmitis between the cases with intracameral antibiotics and without intracameral antibiotics. So you can see for yourself that there is some evidence of benefit, but the studies are all limited because they are retrospective and do not have clear-cut protocols for comparison in a randomized fashion. Next slide, please. So the downside of intracameral moxifloxacin include the lack of Category 1 evidence, high rate of non-susceptibility among coagulation-negative staphylococci, the cost, and the mixing problems. Next slide, please. This is a summary slide from a publication in the journal JAMA Ophthalmology by our group. We looked at isolates of coagulation-negative staphylococci between 1995 and 2016. We were able to test the isolates using frozen bacteria and to regrow them on culture plates and then to retest them against various fluoroquinolones. Even moxifloxacin, shown in gray, had relatively poor coverage. Back in the 1995-1999 period, roughly 20% were non-susceptible or resistant. However, in 2010 to 2016, more than 50%, approaching 60%, were resistant to the coagulation-negative staph were resistant to fluoroquinolones. Next slide. So the conclusion of this presentation is that current data supporting the routine use of prophylactic intraocular or intracameral antibiotics is not convincing. There are numerous downsides of using these intracameral antibiotics. They're expensive, they're toxic, there may be contamination, and they may result in catastrophic complications when using this approach. I would like to thank the organizing committee for inviting me to participate. I'm sorry I cannot be there to enjoy Florence with you, but thank you again for your kind invitation. Goodbye.
Thank you, Dr. Flynn.
Thank you.
Dr. Flynn, can you hear us?
Yes, I hear you fine.
Questions for Dr. Flynn? Yes, Dr. Ozdak?
Thank you, Dr. Flynn. I just want to hear your comments about the ESCRS study, because in the control group, the rate of endophthalmitis was too high. Why do you think it was so? I mean, as far as I remember, the centers were not so qualified in some of the study centers, and most of the endophthalmitis cases were collected in some of the centers. Is that correct? Do you know anything about this?
Yes, your comments are correct, that there was a great variability among centers. There was a variability about how the eyes were prepared, using povidone iodine topically. So there were many issues. It's hard to randomize surgeons as well, because there may be excellent surgeons in some centers and maybe not so excellent in other centers. So there are just so many factors we do not understand. It's a difficult explanation as why the rates were so high in the control group.
Thank you so much. So it's not so reliable then. That's the only study that we have, I mean the randomized study, but the results are not so reliable. Thank you.
Thank you.
Thank you.
Yes, go ahead.
Yeah, may I ask one more question, Dr. Flynn? If I'm talking to anterior segment surgeons and about this issue, prophylactic antibiotics, and they say clearly it is a crime not to use intracameral antibiotics because this is solid study data. And so I fully agree with your opinion, and if you have low infection numbers, that is quite questionable what additional benefit is being done with intracameral cefuroxime. So how would you argue in your country with those people who insist on doing that?
First of all, that's an excellent question, and I have had debates with Dr. David Chang of the American Society of Cataract and Refractive Surgery. We have strong disagreements about this. It seems within the United States there is considerable variability. In California, where the Kaiser Permanente health system is present, they routinely use intracameral moxifloxacin. They have given up on vancomycin, which they used in the past because of the many complications, such as the risk of hemorrhagic occlusive retinal vasculitis. They have also given up on cefuroxime because there was not a commercially easily available product. It required mixing in the United States, so it's not available as it is in Europe. And most importantly, with cefuroxime, there were so many cases of resistance with the methicillin-resistant staph not being covered, whereas strep is covered pretty well. So people now are using moxifloxacin. But our studies in Miami have shown that moxifloxacin is just not very effective against Staphylococcus. I regret that in my presentation I did not show my cases that had received intracameral moxifloxacin and developed endophthalmitis anyway. And I have cases like that. In fact, one of my colleagues at one of our satellite offices went to the ASCRS meeting. He came back home, and his first 10 cases, he developed a case of endophthalmitis caused by a coagulase-negative staphylococcus that was resistant to moxifloxacin. So that was a very instructive case for me, and I plan on showing that case and others many times at future meetings to point out the downsides of this approach. I think the most important issue is good preparation, careful sterile technique, allowing the povidone iodine to be on the surface of the eye for at least 30 seconds, as we do with our intravitreal injections.
Thank you so much.
Thank you.
Thank you, Dr. Flynn. We really appreciate that despite the hurricane, you joined us, and we wish you return back home and in very safe recovery. Thank you.
Thank you. Thank you.